Dr. Suhas Haldipurkar sir operate. I would request Professor Rajesh Sinha, who's the treasurer of All India Ophthalmological Society and consultant at Cornea Cataract and Refractive Surgery Services, RP Center for Ophthalmic Sciences, AIMS, New Delhi, who's going to be co-moderating the session with me to introduce the next surgeon.
Thank you, ma'am. It gives me great pleasure to introduce another wonderful surgeon and a wonderful teacher, Dr. V.C. Mehta, who is founder, director, and chief consultant, Mehta Eye Clinic Private Limited, Mumbai. He completed his medical training and post-graduation from Mumbai University. He was trained in phaco under Professor Leuenberger at Geneva and in LASIK under Dr. Menhard Dick and Dr. Umaid Kermani from Germany.
Hello. Hello.
He has been in private practice for more than 30 years and is currently founder, director, and chief consultant at Mehta Eye Clinic Private Limited in Mumbai. He is amongst the first to start phaco surgery in India way back in 1992, and he has always stayed at forefront by adopting and embracing newer technologies. He has vast experience of using more than 4,000 multifocal IOLs, amongst highest by a single surgeon in Asia. And he's also the founder and chief trustee of CGI Foundation, which offers treatment in eye care at subsidized rates. He has been a speaker at various state conferences, national and international conferences, and has conducted many instruction courses and live phaco surgery and LASIK workshops in India and abroad. And he has a fellowship training program in his hospital in phaco emulsification, has taught many ophthalmologists in the art of phaco emulsification, a wonderful surgeon and a great teacher. We welcome Dr. V.C. Mehta.
It's been a pleasure to introduce our yet another surgeon, Dr. Abhijit Desai, whose experience of ophthalmology, has experience of 22 years in ophthalmology, MBBS graduate from King Edward Memorial Hospital and Seth Govardhan Das Sundar Das Medical College in 1996, did his MS ophthalmology from BYL Nair Hospital in Mumbai, and then DNB from the DNB board. He's a member of several associations, which include the IMA, the Maharashtra Medical Council, AIOS, the BUA, the American Society of Cataract and Refractive Surgery, European Society of Cataract and Refractive Surgeons, and Oculoplastic Association of India. And he is very well accomplished in surgeries, which include the refractive surgeries, the cataract surgeries, toric IOLs, premium intraocular lenses, also in various refractive procedures. And again, we are looking forward to watch his surgery. So with these introductions, I think we move on to the operation theatre of Lakshmi Eye Institute, where Dr. Suhas Haldipurkar would be now taking over and will be telling us about the cases as well as about the surgeries.
Good afternoon, Dr. Namrata and Rajesh. Can you hear me?
Yes, sir.
Yes,
Well, and we can see you. We can see you also on the microscope.
Yeah. Thank you so much, and thanks for this opportunity to conduct a live surgery here. We have 3 surgeries. I'll be starting with the first surgery. As you can see, if you're seeing it on the microscope.
Yes, sir.
Yeah.
Perfect, perfect. Hello.
I have my side port, which is very tight, so that I don't want any leakage. I make a small groove. I use 2.4. Light कडे बघत राहायचं.
You always use.
Yeah.
You always use 2.4?
Yes, I always use 2.4. I have, like most of us, I have realized it is better not to stretch a wound when you want to do an implantation. And astigmatic wise, it doesn't really matter much. And you prefer to use the micro forceps. Rexis, please.
Is this the one designed by you, sir?
Yeah.
So I think we all of us are using this forceps, sir, not only you, because I really feel it has a superb control.
Yes.
So we were having live surgery. I cannot remember. I think it was Arvind Eye Hospital, and we asked Dr. Harpriya the same question, and she said, "This is Dr. Suhas Haldipurkar's my forceps."
Yeah. Thank you.
So what is the size of your capsulorhexis generally?
Right now, I have around 5.1 or 5.2. On the Varion, I keep it for around 2.5.8 and try to stay within. So I end up getting around 5.2. Doa halunaka.
So I think that is slightly on the bigger side because, and I think it makes sense also to have it on the bigger side because then it makes your job a little easier.
Yeah, and especially when you have a denser cataract. If you're working with a very small rexis, you're not really comfortable.
So you ensured, sir, that the nucleus is absolutely free and
yeah. In fact,
very much mobile.
Given a choice, I prefer to have a nucleus which is much freer than now. But then this is good enough because I've had a couple of rotations.
So I feel the importance of you showed so nicely importance of nuclear movement and ensuring that it is there and doing hydro procedures nicely cannot be mind at all. There is some people just like to do hydro dissection and no hydro delineation. Just nudge the nucleus. So I think I completely agree on that front that your hydro procedures, both hydro dissection and hydro delineation, have to be really done well. Yeah, seems a hard cataract. And I think his sir's vacuum is going up to 400, but IOP is very nicely maintained at 44, and aspiration is varying between 20 to 35.
So you are using longitudinal at this stage?
Now, what I'm doing is I'm on a burst mode.
Okay.
So I try to cut it into pieces with the burst mode and then I go into cotton.
Okay. Is it because it's a hard cataract?
No, somehow I have switched over to burst mode. If it's a soft cataract, then I do burst mode with Ozil itself.
Okay.
But in this case, I do it with the longitudinal.
Okay.
So I think burst mode is there, and another option is you can put it in the IP mode. Is it there in the IP mode, or it's just
Yeah,
awesome?
quarterly. Yeah, unless you have IP mode, this OSIL really will not make a huge difference.
Yeah.
I mean, it's not as effective.
Yeah, the ones you put on the IP mode, the followability suddenly, becomes better, much better than without the IP mode.
Procedure 3, please. Especially when you're active centric like this.
Okay, so it's that AS is written, which means that there is active sentry into the. Do you have to, can this active sentry be, how do you upgrade to active sentry? Like we all have machines.
That's a hardware change. Your handpiece will have it. So you have to have a different handpiece for active centric.
Okay, so your console and the machine remains the same, only
Yeah.
what changes is your handpiece.
Maybe they make few changes in the in the software, but otherwise the handpiece is different.
Do you think active sentries actually made a huge difference to?
Yeah, it makes in a sense you can work at higher parameters. You can work at low IOPs, and you can be rest assured that you'll have a stable chamber. I have realized that especially when the younger phaco surgeons work with this, for them it's like phaco is made phaco is made easy because they have much better control. They don't have to really try hard with their foot switch because the machine kind of does most of it.
So I think it has become so simple now that you just remain in the center of the eye. And can we put it on a little bit of retro? Yes, now it's fine.
No, I'll do that.
Yeah. It was there earlier. Yes.
I'll get you.
Yes. Now we can see everything very clearly. Yes, sir.
So is this the jet of fluid you want to
Yeah. No, that is only to loosen the cortex.
Loosen the cortical fibers.
Yeah. Like Kadebaga. Cortex.
You have a bent coaxial irrigation aspiration probe, sir.
Pardon me?
You have a bent coaxial irrigation aspiration.
Yeah.
So that's what you always prefer?
Yeah, that's only because, it makes getting sub-incisional also relatively easy.
Yes, sir. And many people use bimanual. What is your, sir, take on that? Using bimanual routinely
well, definitely, bimanual is definitely an easier option. It's just that, it's easy and you can literally reach all the angles. I think as the beginners, bimanual is the way to go forward. But if you want to have your chamber all the time maintained well, and if you want to cut down on your time polishing, then maybe coaxial works better. Another reason I do it is, you don't need to make too many punctures. And here, because my side port is 0.8, I don't really need to hydrate it. It's just the main wound.
Okay. Okay.
I also feel sometimes that
Yeah.
there is some amount of material, which is especially
Coaxial.
thicker cortex or thicker cortical material, if I may say so, comes out more easily with the coaxial than with the
Yeah, yeah,
biomaterial,
yeah.
Yeah.
which picks up only thin strands. So I think I at least myself also, and I have seen Dr. Rajesh also. We all are very comfortable with coaxial, but this is what is different, that your
Cortex.
coaxial is bent.
Cortex. This one. Now, this patient is for a VBT toric.
It looks essentially like the color is, yellow, but lighter yellow as compared to all the
Yes.
other yellows that we have.
Yes, yes. But it's a great lens to put. Ever since this lesser lens has come, your basket of patients needing this lens has gone up because it's a versatile lens. Obviously, it has one of the finest quality when you compare with multifocals, but the indications have suddenly gone up. I'll come to that after I put the lens.
Yeah. And so what is your target refraction when you are putting these VVT lenses? Is it
like, it depends on the patient. If the patient fully understands that, he'll probably have to have, go for a small ad or minute vision, then I would try and keep him first myope. Otherwise, I would keep him around 0.5, 0.6 or something. But I prefer to put him in the first myope range.
Mhm.
Like
something around minus 0.15, minus 0.2, something?
Yeah. Now that's when I know, and the patient knows that, for fine print, he still needs to go in for plus 1, 1.5. But if he says he would prefer that, then maybe I'll keep around 0.5, and that's a good one.
Mhm. Do you do any mixing of power, sir? Like maybe target refraction of minus 0.5 in one eye and 0.2 in the other?
Yeah, what I do is, I'll just come back. I'll
Yes.
just finish.
Yes.
I completely agree with you, Rajesh. I think that makes sense. You can have the option for both. And now what we can actually see here is the Verion overlay, if I'm not
Yes.
correct. And then I think the axis is being matched with the axis of the lens. You can see the 3 marks there, and the placement of the IOL is done in such a way that the 3 marks align with the axis of the lens. The pupil has become mid dilated. Sometimes it becomes difficult to actually see the markings.
Yes.
When the pupil especially becomes mid dilated, and this is the overlay of Verion. I think it is very, very accurate. It helps you to
See,
see.
now this is a situation where I just make another small 0.8, because in a small pupil, and if you have to, there are two cases there. If you have to, you're using a toric in a small pupil, sometimes it becomes difficult because one thing, you're not seeing the marks properly, and number two, side thought.
So we saw 2 views simultaneously, one from the Verion and another from the operating microscope. Oh, Verion, yeah, this was the 2 views simultaneously. The right one is from the operating microscope, and the left one is from the display screen of the Varion.
Light Kadapagao.
What actually the surgeon sees is what is seen on the left with the axis, which tells you where to actually align the lens. This is what is visible on the surgeon's eyepiece. However, on the eyepiece of the assistant, what will be visible is the picture on the right. So the assistant is not able to see this Varion axis, but the surgeon is able to see in his eyepiece.
Yes.
And what we can also appreciate is, sir, the central bump which is there, or the central bump which is there in the vivity, which I'm sure we are going to discuss about the mechanism of the vivity intraocular lens.
Now we can appreciate that one hole that is visible, one dot that is visible, it is absolutely well aligned with the mark.
Yeah.
That was a perfect demonstration, sir.
Thank you.
Exactly.
Perfect demonstration, even though the people became mid-dilated.
Yeah.
No, at the end, before I could locate, get the lens in the proper location, I had to inject epitrate, diluted epitrate, and with that also the pupil didn't really dilate much. I could only see one,
one dot.
One dot. Yeah, that's it. And what I did was, like if I have to locate it in place in such a small pupil, if you go through the main opening, sometimes the chamber tends to collapse. Yes. And it's difficult. So what I did was, I created another small 0.8 opening, because these 0.8 openings don't really require much. They just close on their own. You just have to hydrate the floor of the main wound and the wound closes. And with that, when you go through the side port where the chamber doesn't collapse, you have a better control on rotating the lens to whichever location you want to take.
That was a wonderful tip, a very nice tip.
That was a learning tip for us also, sir. That was a great trick, and we keep struggling to do it from the main wood. I think
I know.
Very useful to do it from the side port. What about your experience with the Vivity lenses and the Vivity toric intraocular lenses?
Yeah, we were talking about Vivity. In fact, what I feel is with Vivity, although we have been putting this extended depth of focus lenses for a long time, with Vivity, we have obviously come to a next level, simply because either the ones that we used were diffractive based ones. So however much they said these lenses have less of glare and halos, they still had. And they weren't really comparable with whatever deformities were there with the monofocal. But Vivity, obviously, because it's a non-diffractive, it naturally comes in that class. So now, when a patient comes for cataract surgery and he opts for multifocal vision, or he wants to have some amount of near vision, it's another opportunity for us to talk to him about, well, if quality really matters to him and occasional use of glasses doesn't really is a much, then obvious choice is to go for EDOF, Vivity in my case. The second option is, suppose a patient says, I want to get operated, but I only want to get operated for one eye, but I would definitely want some amount of intermediate and bit of near vision. The first choice is Vivity for me, because I have no qualms about just doing it in one eye when the patient wants to come for the second eye much later. And the third thing is, if a patient has already undergone surgery in one eye with monofocal, and now he says, if I can get little better vision in the other eye after the surgery, obviously my choice again becomes EDOF Vivity. So that way Vivity has somehow come in to fill in a gap which always existed.
That's a very important point, sir, because many times these patients, they get operated earlier. In one eye, they are operated, and now they have come to you. And you have so many options. So what to do, whether we can implant any multifocal or any EDOF, any such lens. So you very rightly pointed out that somebody who has undergone a monofocal implantation in one eye, one can safely go ahead with a VVT in the other eye.
Yes.
And in that case, sir, would you like to go for a target refraction of minus 0.5?
Yes. See, if a patient is like, I had an ophthalmologist who said, I'm absolutely okay using glasses to read if I'm required to. So I put him bang on. But then if I feel that anyway he doesn't wear glasses much, but he would certainly do well with the intermediate vision and little bit of clear, I would go first eye half. With half, surprisingly, sometimes they get 6/9 with sometimes N6 or N6 part. So again, I repeat the same in the other eye. So both eyes I put minus half. So they have sufficiently good near vision as well. But again, it depends on each patient. Very often I may do it half in one eye, and I feel the result after 50. See, another thing here is a multifocal. When I put, I may keep a gap of 3 days, but for VBT I keep a longer gap because I really would want to see finally when the lens settles in its place and whatever vision he gets after 15 days, that's when I know how much target for the other eye. So that way also, for VBT it's 15 days gap, whereas for panoptic, anyway I know I want to make him bang on, so I keep a gap of couple of days.
Again, I think that's a very useful tip again. I also wanted to know, sir, about your experience with the Active Sentry now that you're using Active Sentry. How does, and you are such an experienced surgeon, so still, how does it help you as compared to what we were using earlier?
See, with Active Sentry, like you have literally everything in your hand. Like you have your pressure sensors are there without any lag of time. So that means it's so much good that even if you have a leakage through the side port and the chamber tends to collapse, even that is sensed instantly. So that means you can be absolutely rest assured your surge is protected much faster than before. Your parameters you can keep even if you keep very low. Like sometimes you would like to work with low IOP, especially when you have weak posterior pole, or when you have iris which is floppy and you want to keep your IOP low. You can certainly do it because there's always this pressure sensors in the irrigation which kind of sense it and kind of adjust your intraocular pressure and intraocular stability. And plus, if you want to work at very high, like you're a fast surgeon, you want to work with very high parameters, even then it's okay because you have just no worry about surge, because surge is much better protected than in the earlier times.
Okay, I think that is a very useful information again, and that is a very important advantage also.
Yes.
We have the second case, sir, ready?
Yeah. Ready, correct? Yeah, it's getting ready. It's getting ready.
Take that. That should be good.
So, and if I may ask, sir, I have one more question that I would want to ask is, I know that we all understand that although they are, not one for the other, but when would you in a patient plan VBT and when would you in a patient plan panoptics? Or only the economics would decide,
No. Economics just doesn't come here because both of them are the same package.
Yes.
I would go for panoptic when I'm definite that to him the near vision or vision without glasses is of paramount importance, because I know all said and done, extremely satisfied panoptic patients, they are in thousands. That means it only all the glare and halos that they get is only for a week or so, and then somehow they get used to it. So panoptic is a extremely successful lens. But if I feel looking at his profile that I want to give him better quality vision, and for him using occasional glasses is not a huge thing, then I would promote VVT for him and otherwise it's panoptic only. Because my panoptic would be a #1 choice, but VVT is when I know that this patient can be helped by better quality of vision. Because quality wise, definitely VVT would be better than panoptics. It is just that the near vision, and so we slightly compromise and put panoptic for it. But in the long race, both of them do well.
And so one more question for my own learning. Would you like to put any of these lenses in a patient who has undergone refractive surgery earlier?
Well, we have put panoptic, but with this lens, what I feel is VVT would be more forgiving than panoptic when it comes to post-refractive surgery. But the only reason, although I do not want to put it, I would put it because that patient in the first place went in for refractive surgery because he's averse to wearing glasses. And now, if there's some way I can give him, a vision without glasses, I think he'll be happy. And in that case, because your contrast is not compromised, VVT would probably be my choice in a patient like this.
Thank you, sir.
Yeah, thank you.
So I think next case we have Dr. Abhijit Desai, who's going to be operating, I think, on the right eye with a refraction of plus 1.5 and keratometry 45.5 and 46.25 and nucleus sclerosis grade 2 to 3 plus, and we are going to see yet another state-of-the-art intraocular lens. I must say, as far as the material is concerned, it is a very superior lens. And can we have the microscope view, please? Yes. So for us, it is zoomed out quite a lot. Now it's become okay. Yeah. And I think you'll have to put on retro illumination because we can't see the.
Yeah, now it's good.
That's fine.
Very nicely visible, beautifully visible.
So this is a patient with grade 2 nuclear sclerosis with some amount of anterior and posterior subcapsular cataract. Am I being heard?
Yeah,
absolutely, loud and clear.
Very clear.
So we are using the Centurion with the active Sentry, and we'll be operating at the IOP of 26 and a vacuum of 575. Can I have the side port, please? Yeah. So I still use the bimanual. So I make an incision on for the groove on the main sclera. These are money side ports that I use. They have a flatter profile, so they usually don't tend to open up. This okay. Provisc lagana wala. So we are using the soft shell out here. So that's the Viscoat which goes in. Provisc. This is what we are using for the soft shell, which allows the Viscoat to protect the endothelium entry. So we're using a 2.4 incision out here again. I need a cystitum. Me banven maga.
So you're fond of, you do your X's with a needle or with the forceps?
With a needle.
Okay.
Forceps, limbs. We'll try to make a 5.5 mm rexus. So it's good to flatten out the capsule over the radius so that it gives you a good control when you're moving it around.
That was like a compass, you know.
Yeah.
I mean, a perfect control on a needle Rex is just like a compass.
Very nicely done.
Okay.
So I use a 27 gauge needle for the hydro procedure. So I'm going to decompress the chamber a bit, get the capsule out. And then just a small wave which goes like, that's the wave which goes. Please. Madhumat Baga. Am I in focus?
Yeah, yeah. Yes.
So I'm going to be decompressing from the other side. Again, a small wave from here, which makes my nucleus free. Chopper and Peko. One more thing which happens with the 2.4 incision is your flow is uninterrupted. So it really allows your chamber to be well formed all the time. And the machine can take care of the excessive leakage that is taking place. So that's the beauty of working with the Centurion. You clear off the epinucleus part, which is the hard part.
So you mean to say that active sentry helps in this?
No, not this. The active sentry is basically going to help in decreasing the surge mitigations.
Yeah.
Especially when you're operating
if
at
there
lower
is,
IOPs.
Yeah, if there's any leakage, okay. If there's sudden reduction in IOP or
Yeah. So I'm at like 26 IOP with a 575 highest vacuum.
Yeah.
So if I'm going to get a surge out here, that surge mitigation is going to be faster with the active sentry. So this is a softer cataract. It doesn't seem to be a grade 2.
So the IOP that you have kept is 26.
26, yeah.
Is that the usual IOP that you keep?
Yes.
Any variation with the type of cataract or anything that you do, or you are used?
Usually not. Usually not. Only if I do get some amount of surge, depending upon the eyes, which may be hardly 4 to 5% of my cases. In that case, saline on the cornea, please. I increase my IOP to maybe up to 30, 34. Irrigation aspiration. So the trick in chopping the soft cataract is to chop it before the occlusion happens. We just polish off the capsule here. That's my posterior capsular. So one of the good things about the Grishaber bimanuals is it is at a nice angle, which can help you with the polishing of the PC as well.
Yeah. But for all these, it's very essential to have a very good foot control, and that is what I would like to mention here. Because for polishing the capsule, there are two ways. Either you go on the polishing mode, or you, if with experience, you can do it if you have an excellent foot control, as Dr. Abhijit is showing. So that is something that everyone should understand.
Lens. Provis, damn is load करते. So we are using the Clarion here.
Yeah.
So let me just show you this is how the packaging comes as. So it
Yeah.
has a tip which goes inside the
Mhm.
wound, so that you don't have to really do a wound assisted, and can go into the chamber if you want to increase the size of your wound. This is the lock which is there, and this is from where we inject the viscoelastic. Once we have injected the viscoelastic, the lock has to come out. You just pull it out. Now they have a carbon dioxide cylinder in the back of the cartridge, which actually pushes the plunger ahead. Saline. Sorry, irrigation. So what we do is first press the tip so that the plunger starts pushing the IOL ahead, and you make it ready, and you leave the tip again, the tab again, and then you can actually saline corneal. So I'm just going to keep my nozzle as a wound assisted thing and push the IOL in the bag. And using my other instrument, which is the irrigation of the biomanual, I can just put the IOL inside the bag.
So basically, it was hydro implantation, right?
Yeah, hydro implantation. So the advantage is there is no viscoelastic which is there, which needs to be excessively removed. Just a small amount. This much should be enough.
It shortens the duration of surgery as well.
So I just need to do a small amount of hydro here. That's it.
So that actually was a very neat surgery.
Yeah.
It's really a pleasure to watch.
So that's done.
And I think again, like the way you check the IOP at the end of the surgery, it shouldn't be
I
too
don't use
high.
that. Thank you. Thank you.
Thank you. It was really a wonderful surgery. Fantastic.
Thank you, sir.
I just had a couple of questions. One was that what is your experience with the Clarion material of the intraocular lens, vis-a-vis the platform that we used to have earlier?
Vis-a-vis the Acrisoft platform, the
Yes.
Clarion seems to be much better. It's a thinner profile lens with a slightly higher refractive index. It has literally no glistenings, which we used to see with the Acrisoft IOL. And apart from that, with this kind of autonomy kind of injector, it definitely scores way above most of the other lenses which are there in the market.
So again, the question would be, when would you want to prefer Clarion over Acrisoft IQ? I believe.
So in my practice, I have shifted over completely to Clarion over Acrisoft IQ because I find that material much better than compared to the Acrisoft. And plus, if you are trying to explain to the patient the difference between an Acrisoft and a Clarion, it really doesn't justify the amount of time spent in the counseling part as well. So we've made it very simple. So we've just shifted to Clarion instead of
Clarion. So I think materials like Clarion are going to be there for future because of their superiority. Although clinically, I think there is no difference between the quality of vision, etc. But obviously, that is going to be the platform of the future.
Yeah, I think they are going to come with the Panoptics and the Toric as well as the Vivity on the same platform soon, probably in a year or two.
Yes, the only thing would be then again they will have to look at the economics, what will happen to that, because Clarion is more expensive than the Acrisoft.
Definitely. But the ease of which you can actually put in is much better. It's much better than the UltraCert that they were offering. The kind of delivery system the autonomy gives you is much better, and it's more controlled as compared to the UltraCert.
So how good? Yeah, that's what was my next question. That comparing any other system, like we have been using the auto certs for quite a long period. So in comparison to those auto certs, how do you feel is the autonomy injector system?
So the autonomy is as good as the auto cert that which we used to use directly, which was attached to the machine. So that comes very close to that kind of a delivery. It's a very smooth delivery. And other than that, you can stop it whenever you want. So it's not something that goes out of control once you've started injecting it. And it doesn't come out with a jerk like what comes out with the manual delivery.
The shooters.
Yeah, the shooters. So that's something that is really advantage over most of the other injectors which are available.
Yeah, I guess that's a very big advantage because even in one eye, if something adverse happens because of jerky entry of the lens, the shooter, that's going to create a lot of problems. So yes, definitely. I guess as far as economy is concerned, people do understand because it's a matter of their eyes. So
yeah, we did not have any problem shifting to the autonomy or the Clarion, because initial stages definitely there was a hiccup because they had a limited supply, so we couldn't do a complete shift over. But now that they have a complete itinerary and all the range of IOLs, it's easier to manage one particular counseling rather than counsel for 3 different lenses and 3 different types of injector systems.
True, very true. True. So thank you, Dr. Abhijit. It was really wonderful demonstration, very clean surgery, treat to watch. Thanks a lot.
Thank you. Thank you so much.
Thank you so much. Thank you.
So we are going for the third case now?
Yep.
So we are going for the third case, I think, and that is going to be done by Dr. V.C. Mehta, 84-year-old female. I'm sure it's going to be a hard cataract with the best corrected visual acuity of -1 with -1.5 SIL and keratometry of 46.25 and 45.5. So, and a panoptics is being planned in that eye. So can we have the microscope view, please?
Good afternoon, sir.
Good afternoon, sir.
Good afternoon. Can you hear me?
Yes, sir. Absolutely clear.
First of all, kudos to both of you being doing fantastic work for the AIOS, and all the best for the upcoming AIOS at Mumbai.
Thank you, sir.
We look forward to being hosted by you in Mumbai, sir.
Yeah.
Yeah, absolutely, absolutely. बोर्ड बघ हा येस असं करेक्ट.
So good case selection, sir. 84-year-old female.
Oh yeah, she wants to be spectacle free.
Okay.
Why not?
Yeah.
So we have chosen a panoptics IOL for her. Fortunately, her K readings are good enough and don't need any toric IOLs.
Okay.
Yeah, on the keratometry, if you see, there is hardly any astigmatism, but she's accepting a 1.5 cylinder. So
that's a lenticular one.
that one, yeah.
So I think this patient is a very good patient for such lenses, because if she is spectacle free, then her day-to-day activities, particularly at her age when she has to do it herself most of the times, I think she will really be benefited by implantation of a trifocal lens like Panoptics.
Yeah, a lot of time we tend to make decisions for the patient without realizing that they have their own needs also.
Absolutely.
So if you take time and sit with the patient and talk to them, they will probably get ready for the spectacle independence.
Sir.
मावशी लाईट दिसते की नाही? लाईट दिसते आता? आता दिसणार तिथे बघायचं. हो.
So she's going to be done under topical anesthesia?
Yeah, it's on the topical anesthesia. Quite often we have to make the patient realize what light to look at. So what I did was occlude the light totally, and then remove the hand, and they start looking at the light again. Chalu karu? One millimeter they are there, other side port there.
So she would now wish that she would have got the surgery done earlier if she's going to be spectacle free, isn't it?
Yeah, why not? Light kade baga ajibai. We have this 1 mm side port. Swab there, jara. There's some discharge here. Light kade baga. Two 2.2. Yeah. Ocular नंतर.
You use 2.2, sir?
Yeah, I think I asked for 2.4.
Okay.
2.2 dila.
They've
Okay.
given 2.2 because, yeah.
2.4, it is 2.4.
Okay.
Yeah, ocular. So we have seen that 2.4 has less mishaps in injecting the IOL than 2.2.
Yeah, that's what I've seen during all these Surginars now. A lot of people now are shifting from 2.2 to 2.4.
You need to learn to live with some amount of leakage from the main incision, which I think is okay. But you don't want a mishap right at the end of the surgery while putting the IOL. And something that happens beyond your control. So having burnt my finger in 1 or 2 cases, we decided to shift from 2.2 to 2.4, mainly for the IOL purpose.
Okay.
So yeah, we are in Suhas's place, so we have to use his Rexis forceps.
Yes.
And back home also I use Rexis forceps. In fact, I told Suhas, the moment you designed this forceps, my search for a good Rexis forceps ended. So this lady is not keeping steady. Kai sangu नको, kai sangu नको. So that bend in the rexis happened because she did.
Suddenly she moved her eyes.
So I was then onwards, I was little careful in not to tear the capsulorhexis too much and take small steps. So that I have a better control. Now we do the hydro. We first remove some amount of visco. We have the slow wave, we tap, then we go in the substance, and we have that fast wave. So those two waves, short and fast, are important to make sure that the hydro is complete. Additionally, you can inject viscoelastic in the capsular bag so that it separates the nucleus and the epinucleus and the cortex. Dialer. We make sure that the nucleus is free before we start addressing the nucleus. There you can see.
Yes.
Yeah.
So this small procedure of rotating the nucleus before you actually enter with the phaco probe, it goes a long way in preventing a problem when you are inside with the phaco probe and the nucleus refuses to rotate. Now I'm very sure that the nucleus rotates nicely. Well, unlike the previous surgeons, I work at a high IOP. It's around 80 or so. Sculpt. So we now dig a small trench. नहीं. Sinski hook. Light कडे बघा. आजीबाई light कडे बघ. Can't blame her, an 80-year-old lady.
I think every year is important after 80. So 84 to be more precise. She's quite old. But yes,
So there we got a good crack. It's not equivalent, but
No, I just wanted to ask you, changed from chopper to Sinsky while doing this step. So
well, I didn't think that the nucleus is that hard for me to use a sharp chopper, so I gave it back.
okay.
I reserve that for a really hard cataract. This isn't that hard.
Yeah, based on her age, we were also expecting that it will be harder than this.
Well, but the real hardness, you know, when you touch it with your phaco trick.
True, sir. True. That's very true.
So we have a nice small pieces completely separate from one another. That's when we start our quadrant removal. So once all these pieces are separate, you can pick up each one of them. And I have a little bit of longitudinal also, about 10 of longitudinal along with the OZIP. So pick up each piece and emulsify the pieces at the anterior capsular level. You will probably understand why I work at a higher vacuum, because it gives me a very deep chamber.
Yes.
Posterior capsule as well as the endothelium, both are quite away from our phaco tip. माझी अजिबाई लाईट कडे बघायचं, इकडे तिकडे बघू नकोस.
So I think that is just the last piece left. And
So this is a one-handed phaco, if you may call it. So you saw the visco coming out at the end.
Yes, yes.
At the last piece. So visco was there protecting my endothelium. I think Suhas reserved this case for me, knowing that she is not that cooperative. काय आहे? Huh? नहीं, bimanual. Bimanual. So we use a bimanual. I'm used to bimanual right from the beginning. So few things about the bimanual. One is the shape of the bimanual cannula, and it is a very soft eye, so I'm going to put in a little bit of saline before I inject. And you can see the shape of the bimanual. See the tip of the bimanual? It's an arrow-headed tip, so that it goes very smoothly through the incision.
Yeah.
Secondly, when I do a bimanual, I make it a point not to move my aspiration port too much. So we have a tendency to, complete this without changing the hands. That is what should be avoided because it distorts the side port significantly. And being the right eye, it is the inferior side port. So we change hands. So that the distortion of the side port is not much. So these are the few steps that we take to kind of protect the side port from leaking in the post-operative period.
Very important points, sir.
Well, I do polish because I can't resist the temptation of doing it, but scientifically speaking, it's not really necessary. चलो, disco is lens. हा काय आहे? नाही हो अच्छा नाही डिस्को वीज द्या ना आधी डोळामध्ये टाकायचं ना आधी नंतर You guys can understand Marathi?
No, we can't. Don't worry, we don't know what you are speaking.
Right, correct.
Little bit we can make.
मुंबईला यायचं आहे म्हणजे मराठी तर शिकायला पाहिजे तुम्हाला. Just on a lighter note.
Yeah, one or two sentences we can still, we can make out because.
So don't worry, you will survive.
Yeah, we have been traveling so often to Maharashtra that now we can figure out a few sentences.
So don't forget the vada pav when you come to Mumbai.
Yes, sir.
Okay, so we have this panoptic IOL. You can see those rings in the optics.
Yeah.
And we just pick up the lens, load the lens. I wish this comes like the Clarion. Such premium lenses should come with the more better technology. In fact, all the lenses Alcon should provide with the autonomy. I think we should pressurize them,
I think it always is better to have a preloaded system because that also causes less microbial contamination from the surface.
Yeah. So Clarion I sell to my patients on two points. One is a preloaded and two is the cat's eye reflex. The cat's eye reflex is definitely less. Saline, cornea. The cat's eye reflex is definitely less in Clarion than all other lenses. Spatula. Some amount of fluid has light कडे बघ माझी light माझ्याकडे बघ. So she won't look where we want her to. She would look where she wants to. So I had to take that support of the side port.
Yes.
Normally what I do is I ask them to look at me and the whole thing is done. So that's the advantage of 2.4 incision. So now I always put my haptics vertical. We need to spend a little bit of time in centering the lenses after the visco is out. Hydro then? Hydro. So I'm going to hydrate the main wound. Quite often it's not necessary, but it's out of the habit. By manual. Okay, we first remove the viscoelastic. Saline taka cornea varti. And you can see that the main wound is not leaking at all. So we remove the viscoelastic from the chamber and in front of the IOL. Now we nudge the IOL and go behind and take out all the viscoelastic from behind. Okay, now we tap the lens so that it goes back and sticks to the posterior capsule. I would have removed this cortex from the posterior capsule, but patient is not very.
I know the patient is not very.
Not so why take that risk?
Yeah.
So Sinsky. So we look at the Purkinje images of the microscope, and they should be falling in the central zone. And we don't have to move the microscope in order to get it into the Purkinje. So this is fairly well centered IOL hydro. So with the irrigation going on, we hydrate the wound side port. We don't want the anterior chamber to become too shallow because that will cause the movement of the lens or sliding of the lens. Okay, I think that's done. The capsular coverage is fairly good except for this little bit of nudge here because of the patient, and the whole diffractive optics is covered by the just about covered by the anterior capsule, and there's a full coverage of the anterior capsule all around the the haptic, and this is an ideal scenario for an panoptics IUL. Well done. Thank you for viewing our surgery.
Thank
Very
you.
nice surgery, sir. Very nice. And most important thing that every step that you did, you explained why you were doing. That was really nice, learning experience.
Yeah, so I think that was an excellent surgery, sir. In an 84-year-old, it
Yeah.
takes courage to do a 84-year-old on a live platform.
So we just check for the pressure also. If we feel that it is bit too much, release a little bit. So that post-operative period is not stormy for the patient. Otherwise, in the middle of the night, you might get a call that there is a headache and vomiting. So thanks a lot again. There is an air bubble which I'm going to leave it behind.
So thank you so much. I think
Thank you, sir.
excellent demonstration of cases today, including the last case. All the 3 cases were just very nicely demonstrated. And we would really like to thank you for that excellent surgery and, of course, explaining each and every step on how and why to do a particular way, the way you did it. You rightly said we all are tempted to remove the anterior capsular, opacification or the islands that are there. I mean, even though we know it makes no difference. So it was, we all could correlate with all of your surgical steps that you were doing. And so thank you so much. And anything else you would want to give comment on?
Only one comment that I would like to give is when you select a patient for panoptics, no matter what is the K reading and all, we run the toric calculation for all the patients.
Okay.
So we don't make any judgment whether this guy will require a toric or no. Just as we don't make a judgment on the spherical power, we don't make a judgment on the cylindrical power as well. So my optos will calculate for every panoptics, particularly panoptics. And this is the reason why we have a lot of T3s, T2s, and they amount to around 42%. The total torics that panoptics torics that we do is 42% of all the torics, all the panoptics that we do.
Okay.
That's a good number.
So we would like to thank Lakshmi Eye Institute, Dr. Suhas Haldipurkar, the entire Operation Theatre team there who's been working behind the scenes, Dr. Abhijit Desai and yourself, sir, and the nursing staff, the technicians, optoms who made it happen.
Can we see all the, yeah. Now we can see.
Thank you so much.
Thank you so much, sir. Thank you so much. Thank you, Dr. Abhijit, and thank you.
See, both of you, conduct it so well that sometimes when the surgeon is little hyper, he's busy in his working. You carry on so well that surgeon always feels very comfortable.
Thank you so much, sir. Thank you.
Thank you, sir. There was a huge learning experience from wonderful teachers like you, and
surgeries were like music,
Yeah.
It just went on, and you just sailed through like water all along. So absolutely effortless, and so many things to learn, so many tips to learn. Like we always say, they are not given in the books, even if you read, 3,000 pages of a book or you go through the movies, but somebody tells you a very small trick, like that 0.8 thing or any other thing. I mean, small things, Dr. V.C. Mehta and even Dr. Abhijit Desai. Then you pick them up much faster. So even for us, it was a great, many things we learned during this surgical session.
So nice of you.
I mean, if you two have learned, that means it is too much.
Seriously, we picked up small things here and there.
And sometimes I wonder how you can take out so much time for this. We really AIOS really owes to you for conducting such lovely seminars and webinars all the time.
Thank you, sir. So nice of you to say that, sir. Thank you.
Thank you.
Would like
Thanks,
to thank Alcon.
Bye.
Yes, I would like to thank Alcon for arranging this, because it takes so much,
Yes.
their audio video team comes, they have to arrange all, like people like you, and they did a good job. Thanks to them.
Thank you.
And
So,
in getting these people out of their places to come here all the way to operate.
yeah, I'm sure. And
He's come for the farthest actually.
okay,
He's
good.
midway. Borivali is another end from here. Sir.
My God.
Yeah.
Through the traffic.
Yeah.
Don't talk about it. Don't talk about it.
So thank you so much.
Okay,
and
sir.
looking
Thank you, sir.
forward
Thank
to-
you.
Looking forward to seeing you all physically on 2nd of June, 2022 till 5th of June for the physical conference at Geo Convention Center.
Absolutely.
Thank you.
Thank you.
Okay, sir. Bye.